the Multiple Myeloma Networking Group and therapist at Cancer Wellness Center. And I'm excited to have Allison here with us tonight. Grace is a nurse navigator at the Multiple Myeloma Research Foundation. And tonight she is here to tell us a little bit about MMRF, and then we'll present on CAR T cell therapy and bispecific antibodies. And you will all again be muted for a while. You can put your questions down in the chat box, and then after the presentation, I will read some of them to Grace, and she is happy to answer your questions. And that's about it. All right. Well, Grace, welcome. Do you want to add anything to my introduction, or do you want to just get going?
Um, I usually just tell people that I was a nurse in Little Rock, Arkansas at UAMS for 29 years. Didn't last the entire 30 years. With myeloma in different areas before I joined MMRF. Um, so yeah, that's it. Okay, so we'll get started. I'm not sure if everybody is familiar with the Multiple Myeloma Research Foundation, but we're going to share a little bit information about us and what we do. Uh, okay, where do we go? Okay. As an overview of the organization, our vision is a world free of multiple myeloma. And our mission is to accelerate a cure for each and every myeloma patient, no matter where they are. In pursuit of that, we have three pillars that we work around, and it's all centered around including everybody and equity in health administration, so that everybody gets access to the best possible therapies that they can. But our biggest work is in research, and I'll show you a little bit more about where that goes. Um, so Over the years, and we've been 27 years in existence, and over that, the number has changed. There's now over 100 clinical trials that we have opened. Excuse me. Um, the patient survival rate, as everybody knows, has really increased in those years. And we've had 15 at least new drugs brought to market in that time. And then with our fundraising, 90% of our expenses go to research. So that's a big deal for us. Um, right now, one of our current clinical trials is called Horizon. Um, the multiple myeloma does not have its own lab. What we do is we partner with major centers around the country, in New York, in Atlanta, in Chicago, in California. This clinical trial is available around the country, and it's called Horizon, and it is a platform trial, so it's set up in a little bit of a different fashion than most clinical trials. Right now, it's enrolling people who have relapsed or refractory multiple myeloma. Um, it says 9 treatment sites are open, but there's actually 12 right now. And right now, the control arm is a bispecific drug called teclistamab. And after 1 year, if patients are responding well, then they will be assigned to different arms to test effective dosing on this drug, and also including stopping the drug and seeing how well the response continues. So that's one of our clinical trials that's in existence. But I don't know if everybody knows, but Our organization was founded by a lady called Kathy Juicy, who is a multiple myeloma patient. And she was diagnosed with a young baby. I don't know if you've read her book, but she has a new book. Um, and at that time, there was very little therapy available. There was melphalan and prednisone. So she was part of the pharma community. So she was determined to find ways and therapies to help herself survive. But she honestly was told that she wasn't going to make it. So she was going to do it for others. So her and her twin sister founded the MMRF. And thank God she's still doing well. And she really keeps her finger on the pulse, and we still work very, very hard. Nobody has ever like slacked up in seeking therapies that are going to be the most effective for people with myeloma. So that's Miss Kathy there, and her book is called From Fatal to Fearless. So, um, and so the organization does research, but it has us in what we call our navigation center. So there's three of us nurses. There's me and there's Brittany, who came to us from Mount Sinai Multiple Myeloma Program, and then Erin is our manager, and she worked in Connecticut. So we're here, and this is what we do. Here's a little bit, and we will share these slides, but of course you're recording it. But um, what we do is depending on what that person needs when they contact us, basically. That's where we're at. Whatever people need is what we try and answer in that time. But if it's somebody who's newly diagnosed or in a relapse, we're there for emotional support. We also help people connect with support groups, just like your own here. We help people find financial options to help with copays for their drugs or other expenses, sometimes clinical trials. So we do that. We recommend trustworthy resources because we want people to have good, reliable, evidence-based information, not, coming from somebody's friend on Facebook. So we want to make sure people get their hands on the really good stuff. And our myeloma education, I'm going to talk a little bit more about that later. We help people find a clinical trial or talk about the clinical trial that they've presented with to go over the pros and cons and help with decision making. We also have mentors. I'll show you those people. And then we help people find a specialist, which I always say I need to move that to the top of the list because we feel like a myeloma specialist is very, very important for every myeloma patient because they have the expertise and the experience to really help, and their outcomes are better. So there's different ways to contact us. We have our phone number here. It's 888. It's a free phone line. We also have our email address. You can email us. If you scan that QR code, it'll bring you to our page. And the third way on our page is there's a little note, where you can fill in a question. If it's 2 in the morning and it's, you really want to write it down, you can fill it in on the page and send it in and we will answer it. We usually answer people within 24 to 48 hours. So that's what we do. And a lot of the times, and you're all familiar with this, when there's a new diagnosis, there's so much to wrap your head around. So we kind of use a model to help people tick off what are the important boxes. So, like I mentioned before, a specialist is very important, helping people access a center that has myeloma experience. And most people that we talk with, the majority of people, have a local hem-onc doctor, and then they have a specialist who's a bit of a distance, and they see them less often, but they do have that specialist to help plan and guide their care. So that's important. Then we talk about the tests. What do we need for diagnosis? What do we need at time of, restaging? What do we need if there's a relapse? What do those tests look like and what do they mean? We go over all of those. And then treatment is a huge part of it. We talk about for treatment for newly diagnosed people, as well as options for people who are relapsed. So we'll cover that a little bit later. And this is something about our educational offerings. I know there's lots of really wonderful, which is great, organizations out there like IMF and Health Tree and all that who have also good education and Blood Cancer United. But we do have webinars. Um, we have booklets. If people would like um, to send and ask for some booklets, they'll be posted in the mail to you. We also have live streams. We had a live stream today, but it was hosted on YouTube as well as Facebook, and the topic was clinical trials. And this QR code, if you want to point your camera at it, will take you to our education page, and it'll show you what's available. And some of them are there's different ways to learn. Some of them are real short, nice little videos. And then there's podcasts as well, which, if you've got a long drive ahead of you and you want to put in a podcast, we have those available as well. So So, these are some of our mentors. So our mentors are kind of like coaches, like they're called in other organizations, but they're myeloma patients, and they have a little bio. So it shares what they've experienced and what therapy they've been through. But they've been trained to just really talk with patients in any stage of their myeloma journey, whether it's newly diagnosed or in relapse. We also have one, Anna Marie. She's the wife of a patient, so spouses or caregivers can also set up a meeting with people. And, coming from a nurse perspective, we can only go from one side, but these are people who've lived through it and can really give, well, just their own experience. It's still experience of one person, but sometimes they really have a good perspective that people appreciate, and people do really enjoy talking to them. We have one gentleman who is in Chicago. So yeah, so that page, we don't have a link to that page, but it is on our website. And then this is some of our fundraising events. We had a really amazing walk. I don't know if anybody got to go to it in September in Chicago. And apparently it was a beautiful day and everybody had a wonderful time. There was some really good pictures. So those are walks that we have and people fundraise. Then we have people who are going a little further afield on hikes, and then there's bike rides. So people get sponsorship for that, and so that's one of our fundraising ventures. But it's really great to be at those walks because you meet people and we take a picture of all of the living proof. That's the people who have myeloma, but they're there with their families, and it's a good time. So anyhow, so that's all about MMRF and what we do. A little bit of an overview, really. We could be here all day talking about it, but we're going to go on to the objectives of what we're going to talk about. So we want to cover what is early and what is late relapse when you have myeloma. And we want to talk about what are the options available if there's a relapse that people are experiencing. And then also to kind of cover in more depth what to expect with a CAR T or the bispecific therapies, which everybody is talking about. Um, so I like this slide because it just shows, I will not tell you when I started, but it was way back here in the beginning. But it shows where we were at and the 5-year survival rate. Like in 1975, we had minimal therapies and experience in dealing with multiple myeloma. But as the years progressed, see 2014, we're going to have to redo the slide. It's just, it's really accelerated. And right now, the 5-year survival rate, it's only being reported. The last time they reported it was 5 years ago. So it's saying 62% at that time, but right now it's definitely way more than that. So that's where we came from, and this is why clinical trials are so important. All these drugs came from clinical trials, and now they're standard of care. Okay, so this is just kind of a little blurb. We have many different treatment options for a relapse. Therapy choices are always dependent on teamwork, that shared decision making that we talk about. People sit down with their physician, they share their goals for care, they share what they're looking for. The physician gives them options, which we can do nowadays. We didn't used to be able to do that. Um, and then they decide, where to go next. A clinical trial is always valid at any point, even for somebody who's newly diagnosed. Um, BCMA directed therapies, and we'll explain a little bit more about that. But BCMA is a target on the myeloma cell, and it's a way that we can find the myeloma so we can eliminate it. So that's what that big old term means. BCMA directed therapies are very promising, and we've seen some really wonderful results. And they are a type of immunotherapy. So they're mimicking how our immune system really should work. Was it healthy? And was this disease not able to kind of sneak in? In some cases, it's able to be there undetected. And in some cases, people's immune systems wasn't strong enough to eliminate it. So that's a little background on this. Um, so if one thing we know is that patients with myeloma get constant blood work to keep an eye on how things are going. So one of the hints that the disease may be relapsing is those blood works start to change. And so some of these terms, a relapse is a reoccurrence or a reappearance of myeloma. And and it can be really difficult to have that happen, even though we know it's possible. If you've been a long time in a remission phase, it's difficult to have that news come across that looks like it's starting to raise its head again. Refractory is a different term. You hear them together a lot, but refractory means the treatment you're on is no longer working. So the disease is able to come back even though you're on therapy. So you're refractory, you're not responding to the drugs you're on. Progression of the disease is another way of saying relapse. And it's reflected in when they do those myeloma markers. Your SPEP shows the M protein, and then the free light chains are usually done. All of these markers are usually done once a month, unless somebody's been in a really good sustained remission. Some patients do it every 3 months. I know patients who do it every year. So, but that's where they're looking for some, information. Line of therapy is, you'll hear that a lot as well, because some drugs are approved based on how many lines you've had before. And that refers to a change in treatment that is not working or has unmanageable side effects. If you're on a therapy for some months and you have to come off it because your blood work is showing really, decreased blood counts or whatever, then a new therapy, a new approach would be considered a new line of therapy. Um, Early relapse is when you've had a newly diagnosed patient, they've had their induction, maybe plus or minus a transplant. But if it comes back after 1 to 3 prior lines, then that's early relapse. And then late relapse is after 4 or more lines of therapy. And this is a personal note in here, but myeloma patients can see many different lines of therapy, many different approaches, and it's not always a negative. Sometimes it just takes trial and error to hit on the one that's really going to work for you. We have patients who, for example, took part in the CAR-T clinical trials, and some of them had up to 12 prior lines of therapy. They had been treated with 12 different combinations. And they still responded really well to this new therapy. So it is a setback, but it can be managed. So I just wanted to mention that. Oh, and then they clarify for us as well, for a newly diagnosed patient, if you do induction and say you harvest and do your transplant, and then say you go to maintenance. Sometimes people do a period of consolidation. It's not as common anymore, but it can be done, meaning you get chemo after the transplant and then you go on maintenance. Usually that's a one drug therapy. That's all one line. So those are not all different ones. Those are all with the goal of bringing patients to a good response. So in that case, that's one line. Okay, so we're going back to what are the options for patients who relapse. And so if we have a patient who has an early relapse, what we hear the physicians suggest to them is there's a standard of care approach. So there may be other drugs. They may be in the same class of the drugs that patients have had before, but they're different agents within that class. So, for example, in the IMID class, you've got Revlimid. Some people know thalidomide. But then there's a newer generation drug called Pomalyst in that same class. So that could be used in a new combination. Belanrep is a new drug that has been recently approved. That's an option for one, if someone has had 1 to 3 lines. CAR T is now available. The Carvecti, the cilta-cel, can be used in second line, and Abecma is available after 2 lines of therapy. And then clinical trial, we always put that in there. And then relapse in later on. I have to move my column here so I can read it. Again, standard of care with 3 or 4 drugs in different combinations. CAR T therapy, bispecifics, those are available later on, and clinical trial. So that's generally what we see for those different phases of relapse. So this is a little bit more again. So say somebody was on Darzalex for maintenance, because some people do get that. So say you're on Darzalex and you've gone to once a month, but the disease comes back. So the specialist may just change to a different combination, and some of them may be carfilzomib with Revlimid or carfilzomib with Pomalyst, and always with our friend the dexamethasone. The dexamethasone is still, as of right now, a very important player when people are getting active treatment for multiple myeloma. It's usually taken away by the time people have gotten to maintenance, but for a newly diagnosed or for a relapse, you're going to see them use dexamethasone. If somebody was on Velcade, then they may use a different anti-CD38, which is Sarclisa, plus Kyprolis and dexamethasone. Say they were on Revlimid. Some patients went on an induction with 3 drugs and did a transplant, and then they were on Revlimid maintenance. So say they got an early relapse and they'd never used Darzalex, then that's when the physician will put a combination together, usually with a monoclonal antibody. The most common one we hear most of is Darzalex, but they can also use Sarclisa, and they can put in a combination. There's usually 3 drugs with Velcade and dexamethasone. But they can use different combinations based on what the patient has done in the past, and also based on patient's preferences. Like we had a patient who was a pianist and did not want to risk any peripheral neuropathy, so her physician used a different drug in place of Velcade. So there's always room for negotiation. So what is CAR T cell therapy? We've heard a lot about it. It was in a lot of newspapers. It's been everywhere. But it is using our own T cells to find and destroy the myeloma. And T cells are a type of white blood cell. And again, the way they find the myeloma right now with CAR T, the only target that the 2 agents have is the BCMA. There are other targets they're working on, but they're in clinical trial. So there's a flag or a protein on the surface of the myeloma cell, and that's how they are able to find the myeloma. There's 2 that are FDA approved right now. Abecma was first, and then in 2022, Carvecti was approved. And like I said, there's more in clinical trial and in different combinations. The very first Carvecti trial, they have names on all these trials, was Cartitude 1, and now they're up to Cartitude 12. So there's lots of different ways that they're studying this. And so it's still being looked at in clinical trial. Right now, there is no strict guidance. That's one question we get. Say you have an early relapse, what's the best next step for me? What's the sequence of events? Should I do CAR T or should I do bispecific? And there is no strict guidance. So again, it's that decision making with your physician about what would be the best next step. Okay, so what does CAR T look like? You may have seen this already, but if not, for people who've done a stem cell transplant, it'll sound familiar, but you cannot use your stored stem cells for this. You have to do a fresh harvest because we're looking for different cells. But a patient gets a line, usually a line, and they go on the machine, the apheresis machine, see step one there, and they harvest some T cells. Um, they get all the blood out of the patient, they take out the T cells in a little bag, and everything else goes back into the body. And then those T cells are taken and sent away for it. They call it manufacturing, which kind of sounds strange, but they're being processed very, very carefully in very specialized labs. There's one in New Jersey. There's a few scattered around United States now. Um, that processing phase, that second phase, takes a while for them to do. So if a person's myeloma is very active, then bridging therapy is the name they use for some chemotherapy that the patient may get while they wait for their cells to be ready. Had a patient recently who was doing bridging, and she was able to take all oral tablets. She was able to take selinexor, which is an oral drug, along with some steroids and some Pomalyst. So the physician will base this bridging therapy on how active the disease is, how much disease the patient has, how fast it's progressing. Some people don't need bridging therapy. They have a slow progression and they're able to wait out the weeks. And right now, that processing step two can take 4 to 6 weeks. So then you get the news, okay, Bill, your T cells are ready. It's time to come in the hospital. And when this started, people came in the hospital for the entirety of it. But we're hearing now that people are only going in as short as time as possible because there's always demand for hospital beds. And people don't like being in the hospital unnecessarily. So sometimes they get their chemotherapy in the clinic. So they get a type of lymphodepleting. So that is something that's going to bring down the number of T cells that you have and make space for this new product that's coming in. There's two drugs that they use generally called fludarabine and Cytoxan, and it's given over 2 days in the IV. It's not as strong as melphalan for people who've done a transplant, a stem cell transplant, but it can cause some nausea and it can cause the blood counts to drop. It does cause the blood counts to drop and they have to come back up. Not people are not saying they're losing their hair, but some people are seeing some hair loss, but not going bald like after transplant. So you do the lymphodepleting therapy. Sometimes it's done in the clinic, sometimes it's done when you come in the hospital. And then a day later, you get your T cells back. It's defrosted and they put them back in your IV. Generally, you have a line at this point, and then they monitor people for the side effects, and that's step 6 here. So there's short-term side effects and then there's long-term side effects. And we're going to cover them here a little bit. Okay, I have to keep moving my column. Expected toxicities and how they're managed. Am I the only one seeing this, or is that blocking anyone else? Michelle, is it? You can see the whole screen? Okay, okay. All
Yes.
right,
Yeah, I
thank
can see
you.
it.
So the big side effects or the unique side effects that are unique to CAR T are there's two of them. One is called CRS, cytokine release, and the second one is a type of neurotoxicity called ICANS. It stands for something, I'm not going to attempt it, but it's a type of neurotoxicity. So, what can happen for patients once they get those T cells back? If we can, understand that T cells are a type of white blood cell. And during this processing phase, what they do, I didn't cover that, but they multiply the T cells that they've been provided with. So they definitely what they call expand them. You end up with a whole lot more T cells than what you gave them. But they also arm them up with the ability to destroy the myeloma once they're in your system. So what we're doing is we're giving these absolutely Superman type of T cells back into your system. So it's going to set up a type of immune response. So it'll look like an infection. It'll look like fever. It can look like getting short of breath, aches and pains. Your blood pressure may drop. You could get nausea and headache. So headache is usually down here in that second column. So the physicians and the staff are aware of these potential side effects and they have ways to manage them. So that's why you're in the hospital. So they keep an eye on everybody's vital signs very closely right after they get the T cells. Um, it can happen anytime between 1 to 9 days after you get the T cells back in your system. And if you do get CRS, it says 5 to 11 days, but nowadays, I believe people have gotten much better at recognizing it earlier and intervening earlier. So it doesn't get to last as long because they hit it on the head early. There's a drug called tocilizumab that they can give that would dampen down that immune system and stop it, from overreacting. Um, and then oh yeah, there's the treatments. Sometimes you may need steroids as well as the TOSI. And then symptom management means if you're short of breath or you're having trouble breathing, they'll give you oxygen. They'll watch your blood pressure. They'll give you something to bring down your fever, like Tylenol. And then if things get worse, they'll also, give more oxygen or that's when they sometimes add in the steroid. Normally they start with the tocilizumab. And then ICANS is a type of inflammation again in the body, but it impacts the brain. And so they grade everything for side effects. They grade it from level 1 up to level 4. And so most people have a level 1 on these type of side effects nowadays. During the clinical trial, they were more higher grades of 3 and 4 because it was new. We were just learning about what this does in the body. So, so level 1 or grade 1 of a neurotoxicity is headache. Um, but they keep a very close eye on patients in the hospital. They want to make sure that there's nothing coming up that won't sneak up undetected. So they'll have patients count backwards from 100 in tens. They'll have people sign their name or write a sentence once a day and compare handwriting, because handwriting is an early sign that something, might be coming. Um, but some people do get more serious side effects like confusion, not able to talk, not able to walk. And these sort of side effects can come on around the same time as the CRS, between 2 and 9 days after you get your T cells back. And it can last as well. But the treatment is generally the very same. They will give the tocilizumab, they will give steroids. And if there's any concern, they will also give anti-seizure medication. Um, They used to give everybody anti-seizure medication, but that particular medication is difficult for people to tolerate. So I believe they're just giving it if there's a risk or if somebody does have some signs of the neurotoxicity. So these are the what they're looking out for while people are in the hospital. And they generally have the patient stay in the hospital for about 2 weeks. Um, Vast majority of people do really well, which is so wonderful to hear. But then after they're discharged, they do need to stay near the center for an additional 2 weeks. Um, and there's no driving. There's also a driving restriction on patients who do CAR T. So a caregiver is very necessary. I lost my mouse. Okay. Okay, and then the other big thing, it should have been on there, but the blood counts do drop after CAR T, not to the as severe extent as after transplant, but they do drop and they can stay low for a little bit longer than after transplant. So the main risk is risk of infection. So there's different ways that's managed. Hygiene and protection, that's the main one. Vaccinations, once patients are discharged, the physician will talk with people about when to get their flu vaccine back and those sort of things. And then prevention is a big one. While they're in the hospital, patients will get antibiotics. They will have antifungal medications. And we are seeing that once patients go home, their IgG level can stay quite low for a while, up to a year. By a while, I mean up to a year. So normally what we're seeing is patients getting the IVIG, which is other people's immunity. They're giving it to them in a bag. It's usually given once a month, and that's a protection for people while they have their immune system come back and start to be reconstituted again. I think we covered that. Late relapse, what are the choices? Clinical trial always in there. And then bispecific antibody. Um, so these are tremendous, tremendous, absolutely wonderful agents. They're also utilizing our T cells. And the bispecific, the bi means there's two places they hang on to. And and I'll talk a little bit more about what's the difference between CAR T and bispecific. But the main one with bispecific is it's available right away. So say a physician has a conversation with a patient and they have a relapse, he can prescribe it and they can get started, within a week or so once they get clearance and everything like that and get a place in their infusion center. So what these agents do is these agents are able to bind onto one of them, binds them to our T cells in a place called CD3, which is just a protein on the surface of our T cell. And then the other one links on to a target on the myeloma cell. Now, there are three that use BCMA, that's the target, and then they bring that T cell close to the myeloma cell and they deliver their payload of toxins or poison and they cause cell death. They're very, very effective. Um, there's other, is one other that is FDA approved that does not use BCMA. It uses a different, it's just a way of finding the myeloma cell, but it uses a different protein called GPRC5D. That's the target that this particular drug called talquetamab is the name of it. Talvey is the trade name. That's how they find the myeloma. And then there's another one in clinical trial that should be coming to us soon that uses a different target, but it's always to find the myeloma and cause cell death. So let's see what else we tell people. Let's see what's on here. What to expect. Off the shelf is a big one. So there's no waiting for that processing like the T cells in a CAR T. It doesn't require any lymphodepletion, so there's no chemo that you need to do beforehand. They're given sub-Q, but the linvoseltamab, I believe, is also IV. So they're IV or sub-Q. And they have to be given in what's called step-up dosing. So they start with a really small dose. They watch the patient, they see how they do. If they don't have a reaction, they'll do another dose. And after those first two doses, you have to be in the hospital for monitoring for blood pressure and your blood temperature and all of that. And if you do okay, then you can continue on the drug in your infusion center or your doctor's office. Um, some of them are once a week, some of them are every 2 weeks. Um, some of them can be adjusted based on people's tolerance of it. We do see that they're able to lengthen some administration and still get a really good response from the disease if somebody's really having a hard time, because I don't know if we cover this, but the talquetamab has a unique side effect. So we'll cover them. The BCMA specific, the side effects of these are very similar to the CAR T, which makes sense, but they are not as severe. So the grade of them is much, much lower. And generally, if you see a reaction to these drugs, it's with the first or second dose, with the step-up dosing. Generally, once you've gotten exposed to it, then patients do fine with it. They don't develop CRS, after 3 months. Um, but there is a potential in the beginning for the cytokine, like we saw with CAR T, the neurotoxicity. Low blood counts can be a problem, absolutely. So they'll be doing blood work usually once a week. They'll look at your CBC and they may have to tailor the administration based on that. If your white count's too low, they may say, we'll hold it this week. Risk of infection. And then let me see. Oh yeah, here we talk about it here. So the drug that targets the non-BCMA, so the GPRC5D, that one is called talquetamab. It has additional impact that we don't see with the BCMA agents. So apparently, this GPRC5D is also found on some tissues that are lining the GI tract and the skin. So patients can see a rash with this drug. They can see problems with their nails peeling. Um, they sometimes the nails do fall off and then they grow back, and it's just a one-time thing. It's not a continuous thing from what we hear. Um, then the rash, there are ways to manage it. And again, if it's real severe, they'll have a dermatologist check a patient out, and they may have to lengthen this time frame between the doses. The oral one, the mouth one, that's the biggest one that bothers people. It should have been first, but what that can feel like or what that can present like is with a dry mouth or taste changes or difficulty swallowing. So that's a problem. Obviously, we don't want that to be continuing. So that has to be reported. All side effects, of course, will be discussed with the physician. Um, and they don't want it to impact people losing weight. They don't want it to get to that point. So they'll have to use different approaches to manage it. And there are ways to manage it. They may lower the dose of the drug that the patient is getting, the talquetamab, or they may give it less frequently. And then they can also use supportive measures like mouthwashes, dietitians helping out, and that sort of thing. So there are ways to manage it. So I think this is just kind of like a comparison slide. The big plus, and you'll hear this a lot, patients do really like this point for CAR T, is that it is a one-time infusion. It's a one-time procedure, if you will, that you just do. And then most patients are not on any therapy afterwards. They will get their blood work done. They may get the IVIG and things like that, but they're not on chemotherapy or maintenance. Um, there's hospitalization required on both, but it's shorter with the bispecifics. You have to have a good healthy T cells for both. There's no bridging therapy for the bispecific, and there is a caregiver needed for the CAR T therapy, which is it's a big thing. Not everybody has that, and a driver, So um, So that's the comparisons. And then where are we at? A summary. Okay, great, because I'm getting tired hearing myself. Okay, so relapse or refractory myeloma occurs when myeloma progresses or it becomes unresponsive to therapy that the patient's on. The choices will depend on teamwork between the doctor, the patient, the caregiver, and there's lots of decision points. The caregiver being one, distance to travel for a CAR T is another one. It is becoming more freely available, but when it was first brought out, there was very limited number of centers that were doing this. But it is becoming more expensive. But bispecifics are more widely available still than CAR T. Both of them, we didn't even really talk about this, but their responses are really, really wonderful. They're very exciting for physicians to see. Some of the CAR T therapies have 80 and 90% response rate. Bispecifics are very high as well, 75, 80% response rates, which is really wonderful because back in the day, if we saw a 30% response rate, the physicians used to be happy to have a new therapy. CAR T can be used in earlier lines where bispecific, we do see, like I did say that there's no strict guidelines on when to do what, but we do see patients do CAR T more frequently before then going to bispecific. Because for some patients, they do relapse following CAR T and they can still have a really good response, thank goodness, with a bispecific after a CAR T. So that's generally what we see happen, but it's always very patient specific on choosing what to do. And then we had a little bit about taking care of ourselves. It's very important. Complementary care, and we talked a little bit about it, but um, it helps people with myeloma tolerate the therapy, and it also helps them to be comfortable longer. Physical therapy is very much involved in helping people stay active and stay safe. You may not have a really bad time walking, but having physical therapy, if you have, say, a bad back, will help. They're really wonderful people. They'll help people move around safely, and they may have some really good ideas on how to get people more active. A dietitian or nutritional counseling is always important because people's intake can be really impacted. Relaxation, massage, acupuncture, all of those can be used once you clear it with your physician. Emotional support and counseling and support groups are hugely important. I mean, most people know you can't go through this on your own. Spiritual health and practical concerns like, childcare and financial, all of that. We do have a little information and resources for people about survivorship, because with these new therapies, we see people living so much longer. So, what do we do now that people are in this longer survival phase? So, how to look after yourself. We do have a webinar, we have a podcast, and we have this fact sheet that we share. And one of our patients was, we'll quote him at the very end, everybody's myeloma journey is unique. There's more therapies and better treatments, and people are living longer. But accepting your diagnosis and then shifting your focus to getting better, that's his advice to us. And then, like I said, we have lots of resources for people who are survivors to get to that optimum quality of life. So just reach out to us and we will share those with you. So I am going to get to the question point. So what I will do, I think, is stop sharing so that way I can see everything.